My name is Marc Hoffman. I'm the director of the Lymphoma program at the University of Kansas Cancer Center. What we're presenting here is a early phase study. It's a phase 1/2 study with a novel oral CELMOD compound. It is essentially a fifth generation of a thalidomide analog, and I think many of you who have been working in the hematology space for many years are familiar with this set of compounds that started with thalidomide and then went on to multiple generations with lenalidomide, pomalidomide, iberdomide, and now this compound, which is called golcadomide. And I think that there are a couple of things that are worthwhile to discuss. So this particular study is looking at that compound given in conjunction with chemoimmunotherapy for frontline large cell lymphoma. And it is worth discussing why this particular compound was selected in the lymphoma space. There are several features about this. First, the drug is actually a novel compound in the sense that it is the first study that has resulted in complete conformational closure in the closed state of Ikaros and Alos, which results in significantly greater degradation of these proteins and which overcomes even the capacity to do so even with theoretically large doses of Revlimid that are not clinically feasible. You still cannot achieve the degree of target degradation that you can with this compound. So that's one cardinal feature. The second piece is that we did see a lot of activity, obviously, in preclinical models. And the third piece is that this compound appears to localize predominantly in lymphatic organs. So we saw high concentrations of drug in the spleen, lymph nodes, and the bone marrow, which were all quite attractive if you're looking at developing a drug in the lymphoma space. So moving forward to the actual study itself, the study looked at 3 different dosing schedules that were delivered. One was a 0.2 milligram delivered days 1 through 7. The second was a 0.4 milligram delivered days 1 through 7. And the third was a 0.4 milligram delivered days 1 through 10. And there was a phase 1 dose finding portion of the study. And it was determined that due to both DLTs as well as a lack of feasibility, that the 10-day schedule simply wasn't workable. And then the study went on to have a phase 1b/2 dose expansion where there was a randomization between the 0.2 and the 0.4 milligram doses delivered days 1 through 7 of each 21-day cycle of R-CHOP. So patients received 6 cycles of therapy and were treated pretty much in accordance with frontline large cell protocols. The dominant features of this are that we had approximately 80% of these patients that were high risk in accordance with both the LEO data as well as standard IPI data. And the compound performed extraordinarily well. The 1-year PFS across the 0.4 milligram cohorts was 86%, which compares favorably to a number of historical controls. From a safety perspective, we did see some on-target toxicities with increased cytopenias. It should be noted that Ikaros and Alos do lead to maturation arrest of neutrophils, and so neutropenia is an expected side effect, but this is not due to a cytotoxic mechanism rather than a simple cell cycle arrest. There was some increase in thrombocytopenia as well, and this is felt to that activity potentially extending into megakaryocytes. Importantly, we did not see significant increases in venous thrombosis, and we did not see significant increases in febrile neutropenia compared to what one would expect. And so the compound performed well. It had a reasonable safety profile, and we were able to establish that the optimal phase 2 and phase 3 doses will be 0.4 milligrams days 1 through 7 in conjunction with R-CHOP.
Is that help?
That particular combination is about to be the treatment arm on a comparator study called GOAL-SEEK, where there'll be a randomization in a 1-to-1 fashion between R-CHOP delivered for 6 cycles and R-CHOP for 6 cycles, along with the golcadomide 0.4 milligrams days 1 through 7.